Hello viewers, good day to all of you. This is Dr. BK for you with another lecture on the lower limb. So today we are actually going to discuss about the posterior compartment of the thigh, or also called as the flexor compartment. Now in the flexor compartment we are going to see mainly the boundaries or the extent of the flexor compartment, followed by the contents, that is the muscles and the vessels and nerves which are present in the flexor compartment. So mainly the muscles, the flexors of the knee joint, they are called as the hamstring muscles. Then you also have the short head of biceps. The nerve of the posterior compartment is the sciatic nerve. Then a cutaneous nerve is also there, posterior cutaneous nerve of thigh. It is also called as posterior femoral cutaneous nerve. Then the anastomosis of the perforators you see at the back of the thigh. So the extent of the posterior compartment or the flexor compartment of the thigh will be the lower limit of the gluteal region. So the inferior gluteal fold you see here, so that is the upper limit of the posterior compartment or the back or the flexor compartment of the thigh, then up till the back of the knee region. Now if you look at the inferior gluteal fold, if you look at this gluteal fold, it does not correspond to the inferior border of the gluteus maximus muscle. It is a skin fold mainly for demarcating your gluteal region from the thigh. So looking at the cross section of the thigh, so again you are able to see the extensor compartment, followed by the adductor compartment, and then you have the flexor or the posterior compartment of the thigh. Now the extensor compartment is actually separated from the posterior compartment by what you are able to see is the lateral intermuscular septum. So that is the lateral intermuscular septum. Then the adductor compartment and the extensor compartment are actually separated by the medial intermuscular septum. Then you have one more septum which you cannot see properly, the posterior intermuscular septum, which separates the medial compartment from the posterior compartment. The posterior intermuscular septum itself is incomplete because the adductor magnus muscle, you see here this large adductor magnus muscle, takes origin both from the adductor compartment as well as from the posterior compartment. So due to this, what happens is you have a incomplete posterior intermuscular septum. The roof is mainly formed by the deep fascia, which is actually called as the fascia lata of the thigh. Okay. Now, so you are aware of this fascia lata of the thigh and their intermuscular septum. Also, kindly make note of this muscle. You are able to see the biceps femoris. So this muscle also, if you look at it, very closely related to the extensor compartment. We'll speak about it later. Now coming to the cutaneous innervation of the back of thigh, it is mainly by the posterior cutaneous or posterior femoral cutaneous nerve. Then the lateral part is actually supplied by the lateral cutaneous nerve of the thigh. Medially it is by the obturator nerve and lower part is by the saphenous nerve. obturator nerve and the saphenous nerve, lower part of the thigh. Okay. The remaining in the leg, you see the other nerves, mainly again the saphenous nerve, you have the common peroneal nerve and the sural nerve, cutaneous innervation of the leg, mainly the posterior compartment of the leg. Now, if you look along the lateral border of the thigh, that is along 10 centimeters below the anterior superior iliac spine, there is an internervous line. There is an internervous line where you can approach the hip joint anteriorly. You have to retract the sartorius medially, tensor fascia lata muscle laterally. Then you have to push the rectus femoris anteriorly and then the gluteal muscles posteriorly. Then you will approach the hip joint. Now, why it is called as internervous line is no major nerves pass through this, except you have to sacrifice sometimes your lateral cutaneous nerve of thigh. But that is only a cutaneous nerve, so no motor nerves are affected. It is actually called as the internervous line. Same way, anteriorly you also have one more internervous line along the adductor canal. So there also what happens, sometimes you have to sacrifice the saphenous nerve, which is again a cutaneous nerve, so no motor nerves are affected, because if you affect the motor nerve, then naturally what happens, the muscles might go to paralysis. Okay. So posterior compartment cutaneous innervation is by the posterior cutaneous nerve or posterior femoral cutaneous nerve, and laterally by the lateral cutaneous nerve, medially upper part obturator nerve and saphenous nerve in the lower part. The muscles of the posterior compartment are actually called as the hamstring muscles. So here you are able to see the back of thigh, the hamstring muscles, SEMIMEMBRANOSUS, SEMITENDINOSUS, long head of biceps femoris, then ischial part of adductor magnus. Okay, in the deeper plane you see the ischial part of adductor magnus. So that itself somewhat forms the floor for the posterior compartment of the thigh. Now, for the muscles to be grouped under hamstrings, they should actually take origin from the ischial tuberosity. So most of the muscles, all the hamstring muscles, they take origin from the ischial tuberosity. Then they should cross the knee joint and get inserted below the knee joint. Then they should be supplied by tibial branch of sciatic nerve. The tibial component of the sciatic nerve should innervate these muscles, and they are the principal flexors of the knee and extensors of the hip. Okay. Now, in the last slide we have seen some 4 muscles: SEMIMEMBRANOSUS, SEMITENDINOSUS, biceps femoris, and the ischial part of adductor magnus. Are all 4 true hamstrings? No, only the SEMITENDINOSUS and the SEMIMEMBRANOSUS are the true hamstrings. They satisfy the 4 points which we have mentioned above. Originating from ischial tuberosity, yes. Inserted beyond the knee joint, yes. Supplied by tibial branch of sciatic nerve, yes. And they are flexors of knee and extensors of hip. Whereas your biceps and adductor magnus are modified hamstrings. Why? Because biceps only long head is from the ischial tuberosity, short head is again from the femur, linea aspera, lateral lip of linea aspera, supplied by the peroneal component of the sciatic nerve, not the tibial component of the sciatic nerve. The next adductor magnus muscle, again it has got a adductor part which takes origin from the pubis. Then again it is supplied mainly by an additional obturator nerve. Okay, so they are all modified hamstrings, mainly for the functional aspect they are present here. So the first muscle, semimembranosus muscle, from the upper lateral part of the quadrilateral area of ischial tuberosity. Now if you look at the ischial tuberosity, it can be divided by a transverse ridge into upper quadrilateral area and a lower triangular area. The upper quadrilateral area is again divided by an oblique ridge into an upper lateral area and a lower medial area. Upper lateral area and lower medial area, which is the upper quadrilateral area. The triangular area again can be divided by a vertical ridge into a medial area and a lateral area. So actually there are 4 areas on the ischial tuberosity, of which semimembranosus arises from the upper lateral part of the ischial tuberosity. So mainly what happens is it getting inserted into the medial condyle of the tibia. So getting inserted into the medial condyle of the tibia. The upper part is somewhat tendinous or membranous, you can call it as. The lower part becomes very fleshy and it is called as semimembranosus because half of the muscle is membranous. From here, near to the insertion, there is an expansion from this tendon which passes laterally as the oblique popliteal ligament. So the oblique popliteal ligament is a tendinous expansion from the semimembranosus muscle. Then the insertion also extends into the soleal line of the tibia. Okay, along the soleal line. Along the soleal line, again the soleus muscle originates. But there is an insertion, secondary insertion of the semimembranosus muscle. The next muscle what you see here is the semitendinosus muscle. It's got a long tendon. Half of the muscle is tendinous, that's why it's called a semitendinosus. We saw upper lateral part of the quadrilateral region. Here lower medial part of the quadrilateral region from the ischial tuberosity. It arises in common with the long head of biceps muscle, semitendinosus and long head of biceps. Insertion again into the upper medial surface of tibia along with the gracilis and sartorius muscle. So getting inserted into the medial surface of the tibia, not the medial condyle but to the medial surface, upper part of the shaft of the tibia. So here you are able to see the insertion of the gracilis, sartorius and semitendinosus. They insert like a crow's feet and that is why it is actually called as spes anserinus. There is a bursa separating this from the bone which is actually called as the bursa ansarina. So 3 muscles from the 3 compartment, sartorius from the extensor or anterior compartment, medial compartment, the gracilis and semitendinosus, they are like called as gyropes. So thereby they stabilize your pelvis over the thigh. The stabilization of pelvis over the thigh. For this what happens, they act like gyropes. So thereby they hold the pelvis from anterior side, medial side and posterior side. Stabilization of pelvis over the thigh is actually the performing the function of this gyropes. These 3 muscles, semitendinosus, gracilis and sartorius. So you are able to see. So that is how this pull of these muscles near to this insertion, they are stabilizing your pelvis on top of your thigh. The next muscle you are able to see here is the biceps femoris. Biceps, which means it has got 2 heads. It has got a short head and it has got a long head. The long head is actually the hamstring part. Short head, as I told you in the beginning itself, in the cross section of the thigh, it originates from the linea aspera and most intimately related to the extensor compartment muscles. Because of its functional reasons, it is actually present in the posterior compartment of the thigh. So arises long head in common with the semitendinosus and short head from the lateral lip of the linea aspera. Both the heads they unite. Even though it arises in common, the tendon deviates laterally and getting inserted into the head of the fibula in front of the styloid process. So it is the only muscle getting attached to the upper end of the fibula. So the tendon of biceps getting inserted into the upper end of the fibula. In front of it, what you have is the fibular collateral ligament. So because of the fibular collateral ligament, what happens is there is again a splitting of these tendinous fibers from this biceps and also gaining an insertion into the tibia passing along the tibiofibular joint. Same way, if you look at the lower vertebrates, the primary attachment of the biceps femoris is actually into the sacrum, and sacrotuberous ligament is the primitive insertion which is represented in humans as the sacrotuberous ligament. So the sacrotuberous ligament is the primitive insertion of biceps femoris. So because man has gained the erect posture, so naturally what happens, these changes have taken place. The muscles have migrated and some of it have become ligamentous to again give additional support to the joints, especially during weight bearing. So we have seen about semitendinosus, we have seen about semimembranosus, then the biceps femoris muscle. So the next muscle what we are going to see is the adductor magnus. It has got two parts. You are able to see the ischial part behind from the ischial tuberosity. Then you also have the adductor part. Okay. So if you look at the ischial part, arises from the lower lateral part of the ischial tuberosity and as a round tendon getting inserted into the adductor tubercle and the supracondylar line of the femur. And you see a gap for the passage of the femoral vessels that we have again discussed extensively. Again, in the lower vertebrates, this insertion can be seen extending into the tibia. But in humans, what happens is this primitive insertion is represented as the tibial collateral ligament. So from here to the tibia, that is represented as a ligament in humans as the tibial collateral ligament. Okay. So mainly we have seen that the origin of the hamstring muscles are mainly from the ischial tuberosity. So upper quadrilateral area can be divided into upper lateral and lower medial. The lower triangular area of ischial tuberosity is again divided into medial and lateral. From the lateral area, we have seen the adductor magnus. The medial area is actually fibrofatty and it is covered by a bursa. So it is that medial lower triangular, and that medial area is that part of the bone which actually rests on the surface while we are sitting, and it is no muscle originates from that area and it is covered only by a bursa. The inflammation of this bursa is actually called as the weaver's bottom because it is mainly seen in weavers who weave the cloth. Okay. So action of the hamstring muscles you are seeing here, they are mainly the chief flexors of the knee. So that is the main criteria of the hamstrings. They actually flex the knee and extend the knee joint, or it is called as extension of the hip, mainly during walking or standing. So when they flex the knee, naturally the antagonistic muscles, the opposite action you are able to see the extensors in the front of the thigh, they extend the knee. In a semi-flexed knee, the semimembranosus and tendinosus act as medial rotators, whereas the biceps act as the lateral rotator. Okay. So that is their secondary action, especially in a semi-flexed knee. Semimembranous and semitendinosus acts as medial rotators, whereas biceps femoris act as a lateral rotator. So now we are coming to the sciatic nerve. We have completed with the muscles, mainly the 4 muscles which has been discussed so far. Thickest nerve in the body, 2 centimeter wide. So the width of the nerve is almost 2 centimeters. Then you can imagine so how thick the nerve is. From the sacral plexus, again from the ventral division of ventral primary rami. Okay, again you might ask, it is behind the thigh and why ventral division? That is because again for the rotation of the lower limb which had taken place 90 degrees during development. L3, L4, L5, S1 and S2. Sorry, L4, L5, S1, S2 and S3 is the root value of this sciatic nerve. It has got 2 components, a tibial component and a common peroneal component. So you have a common peroneal component and a tibial component. Actually they divide somewhere at a variable distance from the popliteal fossa, mostly coinciding with the superior angle of the popliteal fossa. So that is about the tibial and the peroneal components. So coming to the description of the sciatic nerve, it arises from the lower border of the piriformis muscle, through which it is going to enter the gluteal region deep to the gluteus maximus. So structures under the cover of gluteus maximus, it is present below the piriformis through the greater sciatic foramen. So the greater sciatic foramen is present immediately above the ischial spine, the greater sciatic notch which will be converted into foramen by the sacrotuberous and the sacrospinous ligaments. So emerging from the lower border of the piriformis, midway between the greater trochanter and the ischial tuberosity, midway between the greater trochanter and the ischial tuberosity, it emerges and it is related mainly to the posterior surface of the body of the ischium, but it is separated by all these structures. So they are from above to below. Nerve to quadratus femoris separates the sciatic nerve from the body of ischium, and the tricipital tendon and the quadratus femoris muscle. Then finally the adductor magnus. So the nerve lies successively on nerve to quadratus femoris. Tricipital tendon is superior gemelli, inferior gemelli and tendon of obturator internus. Then quadratus femoris muscle you are able to see, and below that what you see is the adductor magnus muscle. Now an angle between the gluteus maximus and what you are able to see here is the biceps femoris. The sciatic nerve is somewhat accessible. It is a bit superficial because after that it passes deep to the biceps femoris muscle. So that is what in the thigh you are able to see, it is actually present deep to the biceps femoris, and at a variable distance above the popliteal fossa, I told you roughly corresponding to the superior angle of the popliteal fossa. Popliteal fossa is like a diamond shaped fossa. It has got superior angle, inferior angle, medial and lateral angle. Somewhere near the superior angle of the popliteal fossa, it divides into tibial and common peroneal nerve. The 2 components you have, the common peroneal component and the tibial component. The tibial component is medial and the common peroneal component is lateral. So before that it gives muscular branches to the hamstrings, semimembranous, semitendinosus, long head of triceps, and ischial part of adductor magnus. The common peroneal nerve, the root value is L4, L5, S1, S2, and the tibial component, the root value is L4, L5, S1, S2, S3. Biceps femoris is actually supplied by the peroneal component of the sciatic nerve. So usually students have a difficulty in identifying which is the common peroneal and which is the tibial component of the sciatic nerve. Very simple. The common peroneal nerve is closely related to the tendon of biceps femoris laterally, and you can see it is winding around the head of fibula and passing anterior. Whereas the tibial nerve runs posteriorly in the midline downwards, and it is going to divide into anterior and posterior tibial nerve. So tendon of biceps and common peroneal nerve you can identify vice versa. With the help of common peroneal nerve you can identify that muscle is the tendon of biceps, or with the help of tendon of biceps you can identify the nerve closely related to it is the common peroneal nerve. So variations in the origin of the sciatic nerve, there are three types of variations: type 1, type 2 and type 3. So higher division of the sciatic nerve into tibial and common peroneal. So mainly it divides at a very higher place. Sometimes the tibial component pierces the piriformis, whereas the common peroneal component comes below. Sometimes the tibial component arises from the upper border of piriformis, whereas this one comes, the peroneal component comes below the lower border of the piriformis. So these variations should be kept in mind in case of any compression of these nerves while treating the compression of this nerve. So very commonly it is actually called as sciatica. So mainly sciatic nerve can be injured due to penetrating wounds or dislocation or fracture of the hip posteriorly. So when there is a posterior dislocation of the hip, if the sciatic nerve is compressed or completely injured, all muscles below the knee are paralyzed because the tibial component, common peroneal component. Foot drop takes place, like the wrist drop, it is called as foot drop because of the peroneal nerve is paralyzed. Then loss of cutaneous sensation, the leg, except at the medial border of leg and foot because of the saphenous nerve. Okay, so mainly you can expect paralysis of muscles below the knee joint and foot drop. Foot drop occurs not only in sciatic nerve but sometimes, not sometimes, always. Common peroneal nerve if injured also will result in foot drop because of the unopposed action of the flexors of the leg. Okay. So sciatica, again compression of the sciatic nerve from its origin from the lumbar plexus. What happens is, due to prolapsed disc or herniated disc, you are able to see the nucleus pulposus getting herniated due to mainly so many reasons are there. So this herniated disc might compress the rootlets of the sciatic nerve. So due to this, pain radiates from your gluteal buttock region down the leg and can travel up to the feet and toes. So it is actually called a shooting pain or sciatica, which is distributing pain along the posterior part, right, starting from your buttock low down to your feet and the toes. Sometimes the nerve can also be compressed here between the ischial tuberosity and the trochanter of the femur. Compression of the nerve can also take place here when this space is very narrowed down, and by the muscles it can compress. Next, coming to the posterior femoral cutaneous nerve, you are able to see this posterior femoral cutaneous nerve. Again arises from the lower border of the piriformis deep to gluteus maximus, runs vertically downwards it is present on top of the biceps femoris, whereas the sciatic nerve runs deep to the biceps femoris. In the midline of the thigh posteriorly it is seen deep to the deep fascia, but I told you superficial to the long end of biceps femoris. And what happens is it becomes cutaneous after piercing the roof of the popliteal fossa, which is actually covered by the popliteal fascia. Okay, and then it supplies mainly the skin over the thigh, and apart from that in the popliteal region also it supplies. So that is about the posterior femoral cutaneous nerve. Then posterior part of the thigh, you also see these 4 perforators from the profunda femoris artery piercing the adductor magnus, and the ends at the level of vastus lateralis. So each of it dividing into anterior division, ascending and descending branches, and these branches anastomose with each other, forming a chain of anastomosis. So ascending branch taking part in the cruciate anastomosis, with the inferior gluteal and transverse branches of medial and lateral circumflex femoral artery, medial and lateral circumflex. Ascending branch of first perforator and descending branch from the inferior gluteal forms the cruciate anastomosis. The descending branch of fourth perforating artery anastomosis with the superior branch of the popliteal artery, thereby they complete the vascular chain. So they are mainly more of a potential anastomosis, these perforators. So that is about the medial compartment of the thigh and the sciatic nerve we have seen. So thank you for your patient listening, and we will meet again in one more lecture.